seminar. We wanted to give our scholarship recipients an opportunity to share their work with us. And so today we're very happy to have Victoria Riehl-Tonn, who is a fifth-year PhD candidate. She works with her supervisor, Dr. Sofia Ahmed, and her research interests include sex and gender differences and clinical outcomes in individuals living with kidney disease. And her doctoral work is supported by a scholarship from the National Kidney Foundation of Canada. So just quickly before I hand it over to Victoria, just want to do a land acknowledgement. The University of Calgary, located in the heart of southern Alberta, both acknowledges and pays tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, the Tsuut'ina First Nation, and the Stoney Nakoda. The city of Calgary is also home to the Métis Nation of Alberta. And with that, I will hand it over to Victoria. Thank
you. Okay, good morning, everyone. Thank you for that introduction. I am going to be getting started here. So just to disclose, or a little disclaimer, I aim to use person first and inclusive language throughout my presentation. I am still learning and continuously learning, so if you see anything that needs to be improved, updated, or changed, please feel free to contact me and let me know. So my objectives of this talk are to review the concepts of sex and gender in kidney disease and to discuss how sex and gender impact quality of life, but also how sex and gender impact mortality as well, and how it's related and impacts kidney disease. So to kind of go over a brief background on sex and gender. So oftentimes sex and gender terminology are used interchangeably in the literature. However, these are not the same concepts. So when we refer to sex, we are talking about biological factors. So this includes like chromosomes, genes, hormones, and anatomy. And when we report or talk about sex, we're usually talking about biological sex or an individual's sex assigned at birth. So this is usually like what's reported on an individual's birth certificate, but it's identified as female, male, or intersex. So when we refer to sex, the terminology that we use is female, male, or intersex. So on the other hand, we have gender, which is socially constructed, and this includes one's identity or sense of self, as well as their roles and relations. And when we talk about one's gender identity, this is one's internal sense of self, and this can be reported as man, woman, non-binary. This is kind of where a lot of the interchangeability is seen in the literature, where people will either report sex terminology or gender terminology interchangeably throughout their paper, or just not clarify whether they're reporting sex assigned at birth or gender identity. So gender also comprises the interaction of individuals with their social environment, so with like healthcare staff or people that they work with, as well as access to and the use of healthcare systems. I feel like this is really important to acknowledge because we are talking about kidney disease in this presentation and talking about receiving medical care and attending dialysis, which I'll talk about in a later slide. It's also important to note that sex and gender interact and influence each other, and gender exists on a spectrum or on a continuum, and this can change and shift throughout one's lifestyle. So your gender and any component or any of the domains of gender when you're 10 years old may not be the same as when you're 40 years old. So it's always changing. So I'd like to go a little bit more into detail about the different domains or dimensions of gender because I think it's really important. Gender identity is really important to include in research, but I think highlighting the other aspects of gender adds to this work. So like I said, gender is one's inner sense of self, but when we talk about gender roles, this is the These are social, cultural, and environmental expectations and are often shaped by societal norms. So this could include the type of job or a career that an individual pursues, but also the role that they hold within their family, or even the role that they hold like in friend groups. So gender relations is the relation or interaction and relationship between other individuals and how one's gender and other genders influence the relationships. So this can be seen again in family and workplace dynamics. One that often isn't talked about but is incredibly important is institutionalized gender. So this refers to the ways in which gender roles and norms are embedded within and kind of reinforced by societal institutions, such as like one's workplace, educational settings, and other places like that. So a really common example of institutionalized gender would be the wage gap or wage discrepancies, but also dress code differences between men and women, either in academic settings or in professional environments. So chronic kidney disease is a global epidemic, and I wanted to highlight the burden of it. So 1 in 10 Canadians live with chronic kidney disease, and 53,000 Canadians live with kidney failure. And the need for dialysis, which is a life-sustaining therapy for these individuals, increases by 1.6% annually in Canada alone. So what is chronic kidney disease? So chronic kidney disease is an irreversible progressive decline in one's kidney function. So individuals will progressively decline through all, can you guys see the mouse? No, okay. But you progress through all stages of kidney failure all stages of chronic kidney disease and end up with kidney failure. And when an individual has kidney failure or is living with kidney failure, they require life-sustaining kidney replacement therapy. So your kidney's main goal or their main function is to filter your blood and maintain fluid and electrolyte balance, as well as maintain acid-base balances. But really, they're super important for removing toxins and nitrogenous waste products, such as urea. So urea is created from the breakdown of proteins in the liver, and a buildup of urea is really toxic in people. So it's really important that we have removal of urea. But what happens when your kidneys fail? So when an individual is living with kidney failure, their kidneys are no longer able to work or function at all or at the same capacity that they did before. So the kidneys are no longer able to maintain that fluid balance. They're no longer excreting those toxins from the blood. And this can be really harmful to the patients, cause a lot of symptoms, and inevitably will result in death, which is why individuals living with kidney failure require kidney replacement therapy, because it is life-sustaining. So there are 3 types of kidney replacement therapy. I'm going to talk about this kind of backwards, but obviously the main option is kidney transplant. This is not obviously an option for every single individual with kidney failure. Another option is conservative care. So this is referred to as just medical management of their kidney disease, like managing their symptoms of their kidney disease. This is usually just seen as like self-care or management of their kidney disease. Dialysis, on the other hand, is one of the life-sustaining therapies I've been mentioning a lot, but there are 2 main types. One is hemodialysis and the other is peritoneal dialysis. Hemodialysis is quite time-consuming and takes a lot away from an individual's daily life. It's 3 times a week for 4 hours each session, and I'll kind of talk about the burden of that in a little bit, but it's done in-center in a hospital setting. Peritoneal dialysis works through the same way of filtering and cleaning out filtering out the toxins and maintaining and removing that extra fluid that these individuals collect because their kidneys are no longer working. The way that it's done is a little bit different, but it's also able to be done at home. The peritoneal dialysis is like a home-based dialysis option. It provides a little bit more freedom and flexibility and can accommodate, working or being able to maintain your roles if they're towards the household. So to go into a little bit more detail about hemodialysis, I think this will position us well because my projects really focus on the hemodialysis population. So I wanted to dive really deep into what hemodialysis is. So like I mentioned, this is normally done in a clinic or in a hospital setting. It is 3 times a week. It is 4 hours each session. So these individuals are like driving to a hospital for and are there for 12 hours out of their week, every single week, basically forever, until they either get a kidney transplant, they switch to peritoneal dialysis, or they die. So these individuals, like, it takes a lot away from them and can have a huge burden to their daily life. So what happens? So they come to the clinic, or they come to their dialysis session, they sit down, a dialysis nurse connects them to this external machine, this like massive machine that you can see here. What happens is this machine acts basically as your external kidney, or like an artificial kidney. So when the individual is connected, it'll pull blood from the patient. The blood will go through the machine. It'll filter out the toxins, remove excess fluid, and then return clean blood back to the patient. So it takes on the role of the kidneys, because their kidneys are no longer able to do that and are no longer working. So we have this option where hemodialysis can take on that role or help with this. So sex differences in kidney disease. I also want to disclose or disclaim that when I report any findings or any statistics, I'm using the language reported in the papers that I am discussing, just because there is interchangeability between gender terminology and sex terminology. I can't make any assumptions of what's really been reported. So to be true to what the authors report, I say the language they have reported. So now I guess to start us off, there is a higher prevalence of females that live with chronic kidney disease compared to males. However, males will progress faster to kidney failure than females do. So there's kind of a potential sex-based reason for this, and also a gender-based reason, which is kind of why I like to start off that one slide talking about the sex and gender can influence each other, because I'll kind of go back and forth with explaining each of these. But males will progress faster to kidney failure. This could be due to the potential role of estrogen and testosterone. Estrogen might be protective of the kidneys, and testosterone might be a little bit more harmful to the kidneys, thus putting males at greater risk of advancing to kidney failure faster. However, when we consider gender and we consider gender roles, men are more likely to have poor dietary habits or poor lifestyle habits compared to women, and that might increase their risk of progression. So mortality rates are higher in males at all of the stages pre-kidney failure or pre-dialysis. However, there is a bit of a difference when they are actually on dialysis. And men living with kidney failure treated with hemodialysis are more likely to have cardiovascular disease compared to women, again, potentially owing to the poor lifestyle habits. So some gender-specific differences. Men are more likely to start dialysis or transplant as an option of kidney replacement therapy, whereas women are more likely to pick conservative care. So females progress at a lower rate, or slower to kidney failure compared to males. So they're often at an older age when they need to start or have the option to start kidney replacement therapy. So if they're 80 years old and starting kidney replacement therapy, it might not be their goal to be on dialysis and receive dialysis treatment, and they might prefer to do conservative care. On the other side, women might be more likely to pick conservative care if they have a higher role or responsibility towards their household, because it allows them to maintain those roles and responsibilities. This one, my other point will come in later on, but I want to touch upon it now. But men are also more likely to have social support when they start kidney replacement therapy. So they're more likely to be married. They're more likely to have children living at home with them. So they have people around them to support them when they receive kidney replacement therapy, whether a transplant or dialysis. They have someone to drive them to their dialysis sessions, or someone to pick up their prescription, or remember to refill the prescription, or taking their blood pressures at home. So they have a lot more social support, which has also been linked to improved quality of life in this population as well. So women, when they do decide on dialysis as a kidney replacement therapy, they're more likely to pick peritoneal dialysis over initiating hemodialysis. This could be potentially due to that more freedom and flexibility with being at home and able to do your dialysis at home, not being taken away for 12 hours a week. That can be really straining on one's life and really take away from their activities of daily living. And like I mentioned, men treated with hemodialysis have more social support. And again, this has been linked to improved quality of life and improved outcomes for men, because they have more social support when starting kidney replacement therapy. An interesting one is more males are often working and employed when on hemodialysis compared to females. This again could be due to age-related reasons, with males being at a younger age when they're starting hemodialysis because they progress faster. But then there's also the gender component where they might be the primary earner in their household. So they might need to maintain their job while on hemodialysis. But again, that kind of highlights that while working, the burden hemodialysis could potentially have and impose on their work, and having to take away or cut back hours or impede on their work schedule because they need to go to their dialysis sessions. Another one that's not on the slide, but I do like to kind of briefly mention, is just the way in which men and women perceive and report any illness or symptom burden or anything like that. So women are more likely to disclose any discomfort or any symptom burden to their care providers. So this might result in not better care, but more directed care for their kidney disease compared to men. When we look at hemodialysis specifically and some sex and gender differences, research has shown that women, when receiving that hemodialysis at conventional 3 times a week, experience a worse report a worse quality of life and a higher symptom burden compared to males, despite receiving the same treatment. And they're also at increased risk of mortality compared to males. And there are 2 potential reasons that this might be, and both of these can relate to how efficient one's dialysis actually is for them. So the first one is frequency, and the second one is adequacy. But to kind of just give a definition or an explanation, so frequency would be the amount of times in a week that an individual would receive their hemodialysis treatment or go in center to get their hemodialysis. So normally they normally just go in 3 times a week, but females or women might need 4 times a week or more in order to actually see the benefits of hemodialysis and in there have improved quality of life and a decreased risk of mortality. I'm going to go into dialysis adequacy on this slide because I feel like it's just a little bit easier. But dialysis adequacy is one of the main ways we measure really how successful or how efficient one's hemodialysis is. And there is a huge potential for there to be a sex-based difference that might be resulting in worse outcomes for females. So to start us off, KT over V, this is kind of our main point or the main measure of dialysis adequacy. So this is it's a mathematical equation or calculation, and it's used to measure dialysis adequacy, but what it does is it quantifies the clearance of urea, so that waste product that builds up and causes all of those like harmful effects in patients. So the clearance of urea from the blood during hemodialysis. This is a targeted prescription during a hemodialysis run. So we have a set goal, and during the run, they try to maintain that goal of a urea clearance. Next, we have urea reduction ratio, which is another measure of dialysis adequacy that tells us the amount of urea removed during a dialysis session. And this reflects the percentage reduction in the blood urea and nitrogen levels during a dialysis session as well. Then we have ultrafiltration rate. So this is kind of a little bit different and doesn't necessarily directly relate to urea or the removal of urea, but this is the rate at which the fluid is removed from the blood during hemodialysis, which is incredibly important because if we have a dramatic shift in our fluid removal, this can have really negative and bad effects on hemodialysis patients. So I'm going to go into more detail on this KT over V. I think this sets us up and is really the background of my project. But just briefly on the top part here, the K is the clearance of urea, and then the T is the duration of their dialysis runs. So again, it's prescribed as 4 hours. But really, I want to focus on this V component. So I want to focus on the denominator. So however, KT over V is a standardized target or prescription. It's 1.2, but despite potential differences between females and males that could affect dialysis adequacy because of this V. So this V represents the volume of urea distribution, or people will refer to it as the volume of water distribution. But if females, we know, have a smaller volume of water distribution compared to males. So if they have a lower V compared to males, we might think that we're overestimating KT over V, or they might be reaching target because they have a lower volume of urea distribution. However, that's not necessarily the case. When we think about it as a lower V and we have a set target, they might actually be underdialyzed and might need a higher KT over V and actually to actually have adequate dialysis. So inadequate dialysis adequacy and inadequate KT over V can negatively impact symptom burden and then negatively impact quality of life. If those waste products and that urea build up and they're not properly removed during the dialysis session, it builds up in the system and can cause a lot of these symptoms that are really burdening to these patients: the fatigue, the restless legs, the cramping, the pain. These are very common symptoms in this population and are really burdening for them and can cause negative quality of life. So by improving dialysis adequacy, we would be improving their symptom burden and hopefully in turn improving their quality of life. So I want to talk about this really massive randomized control trial that was done. So it was done in like 1999 and published in the early 2000s. This is a sub-analysis of the main randomized control trial, but the HEMO study, the main randomized control trial, really set the stage for defining what an adequate dialysis measure is and how we measure it. So they looked at dialysis adequacy with regard to KT over V and randomized individuals to a high dose and a standard dose. In this sub-analysis, they stratified the findings by survival they stratified the findings of survival by sex or gender. They use gender terms in the paper, but I just want to highlight the graph on the right because this was really their main finding, or like a huge finding in this paper. But when they did their sub-analysis, figure A is women and then figure B is their findings for men. So in women, you can see that they had an improvement in their survival with a higher dialysis dose or a higher KT over V than the standard dose, as evident by that darker line. This was statistically significant. And in men, they found kind of the opposite response. So men actually had worse survival when on that higher dose or when receiving that higher KT over V. Although this was not statistically significant, the trend was really important to showcase. They also looked at cardiovascular mortality and within line with their other findings found that with a higher dialysis dose, they had a decreased risk of cardiovascular mortality. So individuals treated with hemodialysis are at increased risk of mortality, and having adequate dialysis is really important to reduce that risk. However, females may be potentially being underdialyzed, and this could increase the risk of negative outcomes. I do want to kind of play devil's advocate and talk about this double-edged sword a little bit here. If we're talking about improving their adequacy or talking about improving their frequency, this does kind of come at the cost of the individual living with kidney failure. This means more time spent in a dialysis center, more time away from home. It's an increased burden on them, being either with longer dialysis runs or more days at the dialysis center. This can all negatively impact their mental health, can take away from their work, it can take away from their roles towards the household, and it can in turn just have negative impacts on their quality of life. To kind of summarize my background a little bit here, hemodialysis adequacy is a sex and gender blind prescribed target, and my research focuses on better understanding these sex and gender differences and how it relates to mortality and quality of life. So to start us off, I'm going to be talking about specifically the relationship between sex and gender and quality of life in this population. So we recently published a paper looking at quality of life in individuals treated with incremental and conventional hemodialysis, stratified by sex and gender. So our population was incident hemodialysis patients all across Alberta. So they had never experienced a transplant, peritoneal dialysis, or any other form of kidney replacement therapy. And they either were starting twice a week hemodialysis, which was called incremental hemodialysis, or 3 times a week hemodialysis, that conventional dose of hemodialysis. And our main outcome was quality of life. And I'll talk a little bit more about what specifically we measured with our quality of life tool. And then our study design was a prospective study. So we followed our participants up for 3 years, and we administered the quality of life and a gender questionnaire at baseline and then 3 months after they initiated dialysis. So how we collected, analyzed, and reported sex and gender. So we collected sex assigned at birth. Participants in the survey were able to self-report their sex assigned at birth, which we defined as, or our example given was their sex listed on their birth certificate. They were able to answer this at both time points, at baseline and then 3 months after. So this was self-reported, and they were able to select male, female, or intersex. We did look at gender identity, and it was collected in the same self-reported way, but we wanted to look at more than just gender identity. We wanted to encompass all of the domains of gender. So we looked at gender roles and gender relations. So we decided to use this Genesis Proxy gender questionnaire because it has a more encompassing look on gender. And I'll talk about that in just a little bit, but it gives you an overarching gender score of 100 on a continuous scale. And what's used to kind of calculate one's gender score, they look at whether or not they're the primary earner, what their personal income is, if they're the primary person responsible for doing the housework, the amount of time that's spent doing housework, their stress level at home, and then they also included the BEM sex role inventory, both feminine and masculine scores. I'm not sure if anyone here knows this, but this is basically a personality trait. It talks about whether or not you are aggressive or friendly, and that determines if you have feminine or masculine personality traits. This is also just based off of roles in the 1960s or personalities in the 1960s. So from these questions, we get that score out of 100. A higher gender score indicates having more roles traditionally ascribed to women in a westernized society. The lower gender score, closer to 0, indicates having more roles traditionally ascribed to men in a westernized society. So again, to reiterate, we looked at 2 different types of hemodialysis. They were all incident hemodialysis. So again, no kidney replacement therapy. And then we looked at that conventional hemodialysis dose and compared with incremental, that twice-a-week hemodialysis. For quality of life, we administered a standardized quality of life tool in this population. It's called the Kidney Disease Quality of Life 36-item questionnaire. It asks 36 questions, and you don't get one overall quality of life score. Instead, you get 5 subscales or 5 separate scores out of 100 each. But we focus really on their physical component score and their mental component score, or just their physical health and their mental health. So we wanted to see how sex and gender were related to a change in physical and mental health after 3 months in individuals on twice-a-week or 3 times a week hemodialysis. So I wanted to go over what we found with our distribution of gender score. So we stratified by sex assigned at birth and then by the hemodialysis frequency. And again, that higher gender score indicates having more roles traditionally ascribed to women in a westernized society. So they're probably more responsible for the household chores, do more work towards the house, have a higher stress level at home, and probably aren't the primary earner. And then a lower gender score is indicative of having roles traditionally ascribed to men in a westernized society. So again, based on the questions, they're the primary earner, they probably have a higher income, they have less responsibility towards the housework or household chores, and they probably have a lower stress level at home. It's interesting to see that from our population that regardless of their sex and the type of dialysis that they were starting, our participants all across Alberta really were kind of like sitting around a lower dialysis dose, sitting at a lower gender score indicative of having roles traditionally ascribed to men in a westernized society. So to highlight our main findings from this paper, just to get it all out of the way, we looked at males, and in males, both just looking at sex, but then also when considering their gender score, we found no difference in either mental health or physical health. So regardless of the type of dialysis that they were on, whether twice a week or 3 times a week, males did not see any difference in physical or mental health. But when we looked at females, we found that females on a higher dialysis dose had an improvement in their physical health after 3 months, I do also want to state that we did look at gender identity, but our entire sample was cisgendered. So we didn't stratify by gender identity. So this is just reporting biological sex. But yes, so females on a higher dialysis frequency that 3 times a week had an improvement in their physical health. But when we considered or took into consideration their gender, we found that females that had a higher gender score or had more roles traditionally ascribed to women, they actually had an improvement in their mental health on a lower dialysis frequency. So that 2 times a week dialysis improved their mental health. This could be related to the fact that they spent less time at a dialysis center and were able to attend to their roles and relations within their household. Okay, so now to talk about the relation between sex and gender and mortality. We did a systematic review to look at how the relationship between dialysis adequacy and the measures of dialysis adequacy are associated with mortality in both females and males. So we looked at female and women with kidney failure receiving chronic hemodialysis, and I use female and women interchangeably because we did go to the literature where they interchangeably reported sex and gender terminology. And then our exposure for those 3 dialysis adequacy measures, that K2/V, the urea reduction ratio, and the ultrafiltration rate. And then we compared it to men or males on the same treatment. So kidney failure receiving chronic hemodialysis. And our outcome was all-cause mortality. So I want to just go through this chart of how we ended up with the papers that we included. So we ended up, after searching Embase, Medline, and Central, we had 41,000 potential papers to screen and could have been eligible for inclusion into our study. However, after removing duplicates, we had 15,000 that were needing to go through. So we in duplicate screened titles and abstract to see if they were eligible. And then after that, we ended up with 3,600, and we reviewed full text, 3,600 papers. And from that, only 15 papers reported on K/V, urea reduction ratio, and ultrafiltration rate, and the relation with mortality. I will walk through this table for you guys, but we weren't able to do a meta-analysis because there was a lot of inconsistencies in the reporting of K/V in the literature. Whether it was binary, continuous, whatever the cutoff points were, like it was all very different, and they all didn't necessarily report like hazard ratios or odds ratios. They would just report a relation. So we weren't able to do a meta-analysis, but we wanted to still summarize the main findings from the papers to see if it showed us anything that we could synthesize or take away from. So out of those 15 papers, only 9 reported K/V. So on the column on the left, we have each individual paper that reported K/V. In the middle is the outcome of all-cause mortality, and we have it stratified for the results by females and by males. And then I also have a column on the right for female versus male. So some of the papers, clearly only one with K/V, but reported the interaction between sex in the relationship of K/V and all-cause mortality. So this might be confusing, but a down arrow is actually a good thing. So a down arrow indicates a significant decrease in the risk of mortality when there was a higher K/V. So when there's a down arrow, it's actually good. A horizontal double-sided arrow shows that there's no significant association. When there's 2 arrows side by side, that showed a stronger association for that sex or that finding that was reported, and an up arrow would show an increase in risk of mortality when they received a higher K/V. So this is kind of a lot to take in or to unpack, I guess. But really what we found was that females had more papers found that females with a higher K/V had a decreased risk of mortality or an improvement in survival with higher K/V. With males, it did kind of follow the same trend, but it seems a little imbalanced, or like a lot of the papers found no significant association. Some found that it did improve the risk of mortality, and one found that it increased risk of mortality. So there was a little bit difference when they considered males. This one paper looking at the relationship between females and males. So they did report a stronger association with females. So females with a higher KT over V had an improvement in survival, and it was statistically significantly different compared to males. So they had a stronger association. When we looked at urea reduction ratio, it was standard across these 3 papers, which were all published kind of relatively in the same time frame as well. But these 3 papers looked at the relationship between urea reduction ratio and the risk of all-cause mortality. And again, a down arrow indicates improvement, so decreased risk of mortality or an improvement in survival with a higher urea reduction ratio. So all of these 3 papers found a great finding that with a higher URR, higher urea reduction ratio, there was an improvement in survival in both females and males. This makes sense when we consider what urea reduction is and what it tells us. It's showing us the amount of urea being removed during dialysis. And again, when that urea is being built up, that toxins is what's harmful, causing those negative side effects and increases risk of mortality. So when more of that urea is being reduced, we would hope to see an improvement in their survival. And then our final finding here, looking at the ultrafiltration rate and all-cause mortality. Again, we only found 3 papers that reported the relationship between ultrafiltration and all-cause mortality. This is kind of the only one that reported, or was an outlier, I guess, but basically across the board, they found that a higher UFR increased the risk of mortality in all 3 papers. One paper did find that there was no significant difference or no association between UFR and all-cause mortality in males. But 2 out of the 3 papers found that there was a stronger association or significantly worse relationship between females with a higher UFR and all-cause mortality compared to males. Again, this does make sense when we consider what ultrafiltration rate is. If they have a really high filtration rate or rapid fluid removal during their dialysis run, this can be really harmful. It can cause hypotension. It can be really taxing on the cardiovascular system, and it does increase their cardiovascular risk of mortality and morbidity with that really intense fluid shift. So to summarize those findings and hopefully in an easier way, with KT over V, we found that a higher KT over V improved survival in females, and a higher urea reduction ratio improved survival in both females and males. But with ultrafiltration rate, a higher UFR decreased survival in both females and males. And just in conclusion here, the prevalence of dialysis has risen annually by 1.6%. However, females and women, when on living with kidney failure, receiving hemodialysis, experience worse outcomes compared to males, despite receiving the same treatment. And sex and gender-based differences are not well understood, but are important considerations when providing person-centered hemodialysis care. And I'd like to thank my lab